ACCEL continues with a discussion Raymond Gibbons had with Dr. Neil Stone, professor of medicine at Northwestern Medical School in Chicago, Illinois. They discuss statins in the real world, concerns, conundrums, and controversies.
We're going to begin by asking Neil to clarify just what the evidence is for statins as part of the risk discussion that the clinician should have with his or her patient.
Thanks, Ray. Well, we looked at the systematic reviews of randomized controlled clinical trials, and the cholesterol treatment trialists and the Cochrane analysis group were two large meta-analyses that every clinician should know about and be able to discuss with their patients. The cholesterol treatment trial analysis was a per-person meta-analysis. This is unusually robust because you get many more data points. You can look at covariates on an individual basis, and this was done over the past few decades. So we have most of the major clinical trials entered into this per-person database, and that allows them to conclude that there's a mortality benefit in secondary prevention and in primary prevention, marked reduction in heart attack and stroke mortality in these groups. Having said that, the Cochrane analysis group looked at this in 2010 and concluded there was no benefit for mortality in primary prevention, but when they relooked at the data, having now included the Jupiter study, they found out that there was evidence for an improvement in total mortality even for primary prevention. So this gives a strong underpinning to statin therapy, but remember, it has to be prescribed like any drug safely, and people have to prescribe it in a way that reflects those safety concerns.
Okay, so the evidence for the use of statins is strong.
Right.
And that's true even for people with prior events, so-called secondary prevention, or no prior events, primary prevention. And I think our listeners know, though, that there are some controversies about the use of statins, and it would be helpful if you would speak to them. Let's start with the issue of statins cause diabetes.
Well, the initial trial, the West of Scotland trial, in the early part of the 2000s, I think around 2002, came out and said those randomized to pravastatin had less diabetes than those randomized to placebo. But it turned out, when we looked at all the trials since then, just the opposite was found. And in Jupiter, the study that highlighted this, there was a definite increase in new diagnoses of diabetes. But as one analysis found out, for every new case of diabetes, statin therapy seemed to prevent 2 heart attacks, a half a stroke, and prevent 1 death. So you're balancing the idea of it does make the tendency to develop diabetes versus the benefit. When people have dialed down and looked closer, both in secondary and in primary prevention, they found out those with diabetes risk factors were the ones in these trials likely to get diabetes, not the ones without diabetes risk factors. So if you had a BMI 30 or more, if you had an FBS 100 or more, if you had an A1C 6% to 6.4%, or if you had metabolic syndrome risk factors, these were the factors in primary prevention, according to the Jupiter study, that made it more likely you might get diabetes. Those without those factors didn't. And again, in the secondary prevention trials, similar risk factors, overweight, metabolic syndrome risk factors, elevated blood sugar, targeted those who were most likely with a statin to develop diabetes. This led to some people saying it really doesn't take a person who's lean, exercises a lot, has blood sugars of 80 and make them have diabetes. It tends to push the person who's older, more sedentary, already on the path to diabetes to develop diabetes, in one estimation, weeks to months earlier, but certainly not out of the blue.
Okay. Well, I think that helps for that issue. What about the issue of muscle problems or myalgias?
Well, it turns out that everybody has an ache now and then. I actually, before I start a statin, have people do several squats just to see how achy they are. And I always tell them, remember, this happened before I gave you the statin. When we looked at the data for myalgias and muscle problems, we found out, first of all, for the worst muscle problem, rhabdomyolysis, destruction of muscle fibers leading to kidney failure, there was no increase in the groups who got statins versus placebo in the randomized controlled trials. Some people said, well, you selected them out. We would argue you should be selecting out those who might have this problem because you don't want to give a large dose of a statin along with other drugs that would raise its concentration to a person who might be prone to statin problems, such as an elderly woman. So you do need some clinical judgment when you prescribe statins. But what about mild to moderate myalgias? In the new guidelines, we give some advice about this, and we point out that when patients complain of muscle pains or weakness or cramps, it's important to be sure that it's likely due to the statin. Was it present before? In fact, we urge that patients be asked, do you have a personal or family history of muscle symptoms before you give the statin, so you can understand that. Some people with a family history of muscle problems, some people with a family history of statin intolerance, I think it's going to affect that statin decision. And then we show that you should look at other causes for muscle problems. That could be hypothyroidism, vitamin D deficiency. There's a list in the guidelines, but importantly, to stop the statin, let them recover, and then see when you re-challenge if in fact this symptom recurs. Sometimes the switch to another statin is needed. And sometimes after you've tried 3, 4, or 5 statins in a row with these trials, sometimes you need to try a statin, say on a Monday or Thursday. Dr. Thompson at the symposium here talked about that. We find that for people who can't seem to tolerate a statin, pretty helpful, because if they're aching on the day they take the statin, we understand it, but if the aches are very random, we're beginning to wonder if in fact that's what's behind it.
Good. Well, I think that's good practical advice for our listeners. What about the cognitive dysfunction controversy?
Well, I'm glad you mentioned it. Seth Martin from Johns Hopkins gave a very terrific presentation. He first mentioned that the FDA, based only on reports, not on systematic data, said that cognitive dysfunction has been associated with statin use based on case reports, anecdotal reports in those 50 and over, and that it tends to disappear 3 weeks after stopping the statin. But then he turned to the systematic reviews of all the clinical trials that looked at cognitive function. And 2 things strike you. People over 60, when they're tested, have cognitive dysfunction. About 1 in 5 end up not passing every test. And number 2, it's very hard to show a difference between those assigned to placebo and those assigned to statin. In fact, the guidelines said that we couldn't find evidence to show that statins create a major problem with cognitive dysfunction. We realized there were some anecdotal case reports. So we say if it occurs, we would urge the statin be stopped while the clinician looks for other causes, and then in most cases we think would probably continue with the statin therapy.
Okay, I think that'll help our listeners too. Let's get your final take on one important issue. If one of our listeners has a high-risk patient who has prior cardiovascular events and needs their maximally tolerated statin, how do you think the clinician should monitor that therapy?
That's a great question. Some people think our guidelines, because we don't have goals, so to speak, are just set it and forget it. They're not. We urge an initial lipid panel and appropriate safety measures. We don't ask for routine CK or routine FBS, but they may be needed in people. And likewise, liver function might be needed if their initial liver tests aren't normal. That requires a special consideration. But say the normal person, no personal or family history of muscle problems or issues regarding blood sugar, we would check a lipid panel in 3 to 12 weeks, and then we would check it periodically thereafter. And the reason is you need to focus on adherence. And you need to focus on, is the patient getting the proper intensity of effect? I have 2 examples that I think are helpful for the audience. One, a woman whose LDL was 120. She was on 80 of atorvastatin. She started at 160. And I said, Mary, I don't understand how you could get such a poor effect from the statin. How many did you miss in the last 30 days? She said, just 12. So when she improved her adherence, she now had LDLs in the proper range, no problem. And I would argue she got down to about 78 on an optimal lifestyle and optimal intensity of statin. There's no data to show that 68 or 72 or 78 is better. So we think that you don't need a number in that case. But what about the person who's on an optimal statin, optimal lifestyle, and their LDL's left up at 120 or 130 or 140. Well, obviously, this is a person who probably had a genetic problem as well, or had a very poor response to a statin due to some other factors. Here, the guidelines are clear. You can use non-statins. Our preference are those that have been shown effective in clinical trials, and this can help you get the LDL lower. The idea of the guideline is to get the LDL and non-HDL lower based on optimal statin and, if needed, non-statin and lifestyle therapy. Remember that the LDL responds beautifully to statins. Lifestyle is going to really improve the non-HDL. So if you're used to watching non-HDL, we didn't say you can't watch it. We're just saying there's no number which if you just miss, you have a problem, or if you just make it, you're out of the woods. We want optimal adherence to proven therapy. That's what the guidelines say.
Well, thank you, Neil. I think you've highlighted many of the practical concerns and issues about statin use for our listeners to help them in their everyday practice of preventive cardiology. Thanks for coming to ACCEL.
My pleasure. Thank you.